I'm very excited to facilitate this with our fabulous panel up here. So first want to recognize past presidents that could not be here with us. So we had first Nell Ann Peck Woodridge. She was the founding president. CMSA was founded in 1990, and our first president then was 1991 to 92. Next, we had Mindy Owen. She could not be here with us this year, 92 to 93. Gary Wolf, 94 to 95. Mary Gambosh is deceased, sadly. She was our president from 1995 to 96. We have Marlise Severinsen, was 1996 to 97. Cynthia Whitaker was 97 to 98. Kathleen Morio was here at the beginning and had to leave for a work emergency. She was 1999 to 2000. We had Sandra Lowry, 2000 to 2001. And Kathy Malahi, 2001 to 2002. She was planning on being here and had a family emergency. So please keep her and her family in your prayers. 2004 to 2005, Sherry Aliada is 2000, well, as I said, and then 2005 to 2006 is Susan Rogers. And Connie Commander, 2006 to 2007, also had something come up, was going to be here. And she's from Houston, Texas, my hometown. And Peter Moran, 2007 to 2008. Jeff Frater, 2008 to 2009. 2009 to 2010 is Peggy Leonard. She so badly wanted to come, but had an issue where she sadly could not be with us. 2010 to 2011 is Terry Triger. So our list of acclaimed past presidents, our current president, and our president-elect that are up here. We'll start with Carrie Ann at the end. Carrie Ann Ingham, hi. You're like, oh, me first, thanks. Oh, really? So you're in trouble. Is that what that means? With that, Carrie Carrie began her career in case management in the late 80s and has experience with health plans representing all payer systems, had her own company in catastrophic case management for 13 years, provider organizations, hospital-based case management, and now contributes to the healthcare system in quality and accreditation for Medicaid health plans in Florida. She was the recipient of CMSA's Case Manager of the Year Award in 1997. Nancy Skinner. Nancy has, for the past 30 years, served as a case manager, director of case management, and international case management educator. She's currently the principal consultant for Riverside Healthcare Consulting, received the Case Manager of the Year Award in 2002, the Lifetime Achievement Award in 2008. She's also an author and involved with many organizations in the healthcare industry. We have Jeannie Bowling, is a former executive director, and she was the executive director for CMSA from 1994. Okay, God, I knew that. Just left my opioid presentation. Yeah, I just and had to run. 1994 to 2006. Okay, got that in. All right, and so Jeannie was the executive director through that, brought through so many fabulous programs, very beloved. So many presidents served under her. She led CMSA to just huge success, and works with Kathy Malahy in Kathy's then company of, because she was on here, Malahy and Associates. All right, okay. Karen Chambers is exciting to see too, both you and Carrie, and everyone else. I just haven't seen y'all in a while. Karen is VP of Clinical Outcomes of Navi Health, one of the nation's largest convener in the CMS Bundle Payment Program, and a leader in post-acute care management. Karen has over 30 years of healthcare experience in case management and managed care. She received the Case Manager of the Year Award in 1995. Ann Llewellyn. Ann Llewellyn was president, and I didn't say the years, did I? Karen was 2002 to 2003. Ann Llewellyn was 2003 to 2004. Has experience as a catastrophic case manager, workers' comp, and long-term care. She also has experience in training and development. She is currently working as a digital journalist, nurse blogger, and mentor, sharing information to consumers and members of the healthcare team with the goal of improving the delivery of healthcare. She received the Lifetime Achievement Award in 2015. Mary Beth Newman. Mary Beth has 30 years of professional experience with over 20 years of experience in health plan, clinical care management, operations, spanning commercial, Medicare, Medicaid populations. She is currently the Senior Assistant Vice President at EXL Service, providing consultative expertise to support both business development initiatives and global clinical operations. Mary Beth was the recipient of the Case Manager Year Award in 2014, and I was honored to co-chair with Mary Beth for the 2016 Standards of Practice, and so served on the board with her. These aren't on, and they're driving me insane. Well, there we go. It's just going to stay. Now, next, our current president, Mary McLaughlin Davis. And Dr. Mary McLaughlin Davis is a senior director of care management for the Cleveland Clinic Health System and an adjunct nursing faculty member at Ursuline College. She has provided care coordination services for inpatients, outpatients, and health care plans. Dr. Davis, as a clinical nurse specialist, has worked extensively with patients having chronic disease, notably congestive heart failure and stroke. Incoming President Dr. Jose Alejandro. He is the Director of Case Management at the University of California, Irvine Medical Center and Adjunct Professor at South University. Jose has served, it says, I won't even tell you how it typed out, several terms on the CMSA board, as well as many leadership roles in several healthcare organizations, as well as within the military. Jose was the Case Manager of the Year recipient in 2015. And then y'all know who I am, and I'm a past president as well, 2014 to 2016, owner, CEO, president of Fraser Imagineers Association Management Company, and the executive director. I've been a nurse for, and I'm reading it, how silly, 40 years. I tell you, racing from 90-minute presentation, yes. Heads will roll, who did that scheduling, yes. Including, so I was 40 years being a nurse, because in Texas you can go to nursing school in the first grade, I always add, in hospital, which included emergency room, labor and delivery, and as a director of nursing. I became a case manager 25 years ago, creating the first case management department for a large national hospital/long-term care system, and I was the recipient of the 2016 Case Manager of the Year Award. So we're very excited to have all of you here, even those of you way in the back. That won't get you to move up yet, will it? So, all right. How we're going to do then is we had done a call out for questions, and that I will ask any of those that came in, and we had then 3 that through this call out that came in, and I'll kind of prime the pump first with those questions that came from attendees, and then once those have been, I'll ask our specialists that then it will come out to the audience. And we have microphones set on each side halfway down. So if you have a question for our panel, please come down to the microphone and then where you can ask that question. And they've given me the very dangerous thing. I have a remote for the timers. I may bring them with me on the stage tomorrow, where when my time goes down, I could just hike it right back up. But what we're going to do, I think that's why they gave me this giant box. I thought it was going to be like a TV remote. This would be hard to sneak on there. So I will start the timer at a minute, and has been what had been kind of recommended for each response to the question. But if they're still talking, I can repeat it or restart it. They call it repeat, but restart it at that point. So, one of the first questions that came in: what challenges do you face with upholding the standards in your organization? And I think I'll start with, if Jeannie Bowling, could you give an answer to that?
Well, the standards of practice for case managers, CMSA standards, are probably the single most important document that each of us has. What challenges you face, one of them is making the standards consistent with the position descriptions, with your mission statement for the case management department. Another is making sure that other departments in your organization know what they are, specifically the legal department or quality, the administration, and marketing departments. All departments that you cooperate with need to know who you are, and the standards are the single most important umbrella of protection for those. And I think my time's up.
No, if you're in the middle of a sentence, I can repeat.
I glanced over
I was just going to see if she was that amazing and stopping right on that zero it was looking. No, carry on.
I think
you were done. I thought so,
you.
And that was amazing. You surprised yourself, didn't you? So, Mary Beth,
yes.
Since I worked with you
yes.
on the standards, what would you say to that question? Does it need to be, you want me to reread it, or you're good?
No, so the challenges, one of the big challenges I think that we face within our organizations regarding the standards of practice is putting those standards of practice into everyday practice. So it starts at the high level, as Jeannie mentioned, making sure our policies and procedures are aligned. We have to know, who are our stakeholders, what's our business model, and demonstrate to our leaders within the organization how the standards help uphold and help us meet our strategic objectives, how the standards are completely aligned with what the business model is. Then we're all speaking the common language, and that helps us put those standards into everyday practice. And I think that's where the rubber hits the road. And it's not hard with case managers. We're passionate about what we do. We love what we do, and just tapping into that passion is one of the great ways to implement the standards of practice.
Fabulous. Do any of the other panel members want to add to that? Ann?
Thanks, Kathy. Thanks for everybody for being here today, too. It's great to see you this late, because I know we're all tired. But I think the challenge I see in education, as I try to educate people, is that many people aren't using the standards or don't know that they even are there. So it's been great. CMSA has them on the website. You can download them for free at cmsa.org/SOP. And so I think it's just important that you go back there, if you haven't read them in a while, to read them again. I recently did a presentation and I talked about the case management standards of practice, so I had to really reread them and learn them again. And it was really enlightening how much they really are a part of our healthcare system today and help us keep our compass. You know, they say the true north. Those standards will help keep you focused on what our roles are and our functions. So just take a look at them again if you haven't seen them in a while. They're really important.
Carrie?
Yeah, one other thing too is, just to build on what Ann was saying, is I really feel like it's very, very important for us to make sure that even as practicing case managers, even if all of our standards are aligned with our model and everything's going great, the standards are updated on a regular basis every, 3 to 5 years, something like that. And that's a really important thing because there are a lot of changes. As we all know who have been in healthcare for a while, change is the only constant in healthcare, and that's going to continue. And so as we move forward, we want our companies, we want our practices to move forward as well. So it really is a good practice to go on, become more familiar with the standards. When there is a new release of standards, it's really good in your organizations to train everybody on those standards. Make sure that the people in your company who are in compliance, in quality, and as well as your own department really understand what those standards mean and how they're being utilized in the organization on an everyday basis.
Wonderful. Anyone else? Jose?
Sure. So I think the very first thing that has to occur is that you really need to understand what the role definition of the case manager is within your organization and what the roles and responsibilities are before you can really understand the challenges with upholding the standards. Oftentimes what happens in different organizations is that if no one else wants to do it, then let's assign it to case management because they're the catch-all department in the area. So it's very difficult to truly understand what the standards and how they apply without really having a clear defined role of the case manager within the organization.
Thank you. Can y'all turn the mics to a point they're echoing on everyone? If y'all can have somebody fix that. I know that's maddening for the speakers. Thank you. Anyone else with that? Are we ready for another question? That's all. Those are great. Thank you. All right, next. What can we do to allow the case manager to do real case management and less administrative paperwork? That's a loaded question, isn't it? And very, very hot topic. So, I know it. Did you send in that question? So, Karen, would you like to?
So as those who know me, Kathy, I am a big fan of technology. I look back several years, and at one point, not that many decades now ago, I would have, you said mouse, and I would start looking in a corner. And now I'm in my second company where I help develop our case management solution. So my advice is always to embrace technology and use it to your benefit. So many times we don't always utilize the full capabilities of the system, or it's not configured right because we have this gap between clinicians and IT. We don't always speak the same language. And it's very difficult and frustrating sometimes to try to work with that group to make sure you do have the appropriate. And I think the other piece is we tend to want to tell the story. No matter if we have a checkbox, we still are, I find this especially with our clinicians, we want to write about it as well. We want to tell that story. We have to sometimes limit ourselves and have something that conveys the message without going through as many layers as we sometimes want to.
Well said. Well said. Mary.
I think oftentimes our administrators may or may not be clinical or they may or may not be case managers. And the further they are from the clinical piece, in my view, the more difficult it can be to make the case for why case managers need to do what they do and not be the catch-all department, as someone else just said. So case managers, we have a certain personality of being assertive, and we have to be respectful but make the case to our administration as to why the value of our work is in our actual clinical work and not in doing administrative work or work that can be delegated to a non-licensed individual. So I think, there's dangers on that line being blurred on both ends, where administration, if they're not familiar with case management, will want a non-licensed person to be doing our work. So we really need to guard our profession that way. And I think also if you report up to a business administrator, you have to do a business case for why it's important that we do the work that we do and not do everything that no one else wants to do. And I know in the hospital world that is kind of a constant battle. I'm sure it is in every other setting where care managers work. But this is what we're very good at making our case, so I think we have to stand up and do that.
Thank you. Nancy, do you have anything you want to add?
I don't know how much I want to add, but I will say that as case managers, our primary function is always being patient advocates. And if we advocate for our patients, sometimes that includes raising our hand and saying, this responsibility that you're giving me, beyond what my responsibility is to the patient I serve, this additional paperwork, I need to document the responsibility and the actions that I have performed on behalf of my patient. But this other minutia that you're giving me, this other stuff that you want me to do, is outside the scope of my practice, and maybe I need that extender, maybe I need that technology that Karen talked about to help me be more efficient and effective in the delivery of case management services to those patients.
That's wonderful. Thank you. Does anyone else want to say anything on that topic? Carrie?
I think it's difficult today in some settings. I'm sure that with all the people in this room, y'all are doing different jobs in different kinds of settings. And so in some settings, there are abilities to really have a very close connection with our members and our patients. And in other settings, it's difficult to do that because of resource constraints, because of a lot of things, including administrative paperwork and things like that. So I think that there are times when people get very frustrated because maybe they can't spend as much time as they would like to, or the program is a little more fragmented. And again, as Nancy said, I think that we need to look at ourselves, even if we're doing the case management and we're not in a managerial position, we have to look at ourselves as really being the experts in this area and raising our hands and saying, I think it might work better in a different way. And I think a lot of today with consolidation of many companies and different things like that, the law of large numbers, how difficult it is at times to really spend a lot of time with some of our patients. We really have to identify those patients and those members that need the time and take a look at raising our hands and being part of that discussion within our own organizations.
Thank you. Anyone else? Okay. All right. This one's kind of a two-parter question. How does a case manager best prove their worth and value? And then what are the challenges and how do you overcome them? So why don't we start with how does a case manager best prove their worth and value? So Anne?
Well, I think letting people know who you are, that you are the case manager, their case manager, and listening to the patient or their family to find out what their needs are and helping to meet them. I think probably everybody in this room has had that experience of being told, I wouldn't have gotten through this if it wasn't for you. And that is a success, and that's what we aim for. So, and then bringing those compliments, bringing those kudos to yourself, keeping a record. I mean, I have letters from patients that I worked with that I look back on even still today and make me feel really good because I did do a good job. So we have to celebrate our successes, celebrate the good work that you do, and keep it up front, let your supervisor know. This patient sent me this note, I thought it was so nice. Because sometimes we forget to do that. We forget to give ourselves the credit for what we're doing.
You're great. I'm not even putting the timer on. They're so good. Karen, how about you?
I'd love to. With my role over clinical outcomes with our organization, you have your standard, your financial, your ROI, how do we make the business case for what we do, and you also have your clinical outcomes that we all measure. One of the recent emphasis we've really started focusing on is that patient experience. So we started with surveys, and the first question we asked is, do you remember your case manager? And 50% of the time, people didn't remember who their case manager was, which tells me we're not doing a good job of engaging. So I think it's really important to, how do we measure the effectiveness and the value of how we're interacting, because that patient engagement is what holds the key to how successful we can be, because getting that patient's cooperation and buy-in is what we should be doing.
Nancy.
This morning in the keynote, we heard the physicians say, tell your stories. I don't think we do a great job of telling our stories. You do amazing things every single day that make a difference for the patients we serve. Tell your stories. Now I know there's HIPAA and all those rules, and we've got to be careful of those. But what a difference you make for those patients. But we don't tell those stories. We focus more on sometimes the things that didn't work as well as the amazing things that we've achieved. So let's start telling our stories. And I need just one more moment to say we hear an awful lot about public policy from the folks that lead this organization. Let's start telling the stories that we have achieved with our patients to the people in Washington, D.C. that have no idea what we do, why we do it, and the importance of what we do. So tell your stories. That's how we prove our worth and value.
Jose, can you add to that or anything?
Sure. I think one of the things that as a case manager, whether you're a director, a supervisor, manager, or an individual case manager is, you need to understand what the organization thinks worth is. So having a defined definition and expectations, then having that approach. I've worked for several large organizations where I was told when I first got there, you can't have any more case managers, you can't have this, you can't have any more social workers. But within a year, I had everything I needed for whatever programs. So understanding what the program requirements are, understanding what the needs are, but more importantly, understanding what the value is. So learning how to do a pro forma or actually doing an ROI so that you can demonstrate what the actual worth is. So oftentimes, if you're in the financial world, if you're working with the CFOs, they're very black and white. So there are several avenues to actually talk about the experience, but if you're talking to decision makers, it's really about them understanding what you're building, why you're building it, and at the end of the day, what the clinical outcomes mean to the financial outcomes, which really tells you what the organization's for.
Anyone else have something with that they want to talk to?
I want to just mention we had the writing workshop on Wednesday, and I see a couple people who were there. And I think you know, we had some writing exercises that people did, and one of the questions was for case managers to write their elevator speech of who they are and what they do. And it was amazing in a 5-minute, 10-minute period what people came up with. I know Brianna took some videos of people as they were talking, and I think they're going to be on the loop of some of the screens here, so you'll get to hear them. But again, that was just a 10-minute exercise, and people didn't know we were going to ask them that question, but they were able to come up with it pretty quick. And it was really amazing to hear. It made me really proud that people are proud of what they're doing and the work that they do in settings throughout the healthcare system. So I think we are doing that.
Now, the second part then to this question, what are the challenges and how do you overcome them? Jeannie, would you want to add to that?
I think one of the main challenges is that we may perhaps expect the administration or the folks that are guiding the organization to understand what case management is or to tell us. Just the reverse is true. We are the advocates for the patients, but we're also the advocates for case management. We're the ones, as Nancy said, to tell the story. We're the ones to educate the marketing department. We're the ones to let the administration know what we do. We're the ones to connect with the nursing departments and the therapy departments and let them know what we do so that we can coordinate and cooperate well together. So it's our responsibility. We own it.
Mary?
I would definitely agree with that. I think
Probably lean forward maybe a little
sorry.
bit. No, you're fine.
I would definitely agree with that we are the keeper of our future. So as I mentioned before, writing a business plan, if you need more employees, and they said you're at your max, then you need to write up how that is going to actually save money or even bring in money, because that is, that we are financial organizations, we're also people organizations. Right now, the outcome measures that we're all held to are tied to financial pieces, also. So in the acute care world, readmissions is definitely a financial piece. So how do you, if you start decreasing your readmissions and also don't increase your length of stay, or just different ways you can look and say, we're helping our patients tremendously. We're transitioning them to the next level of care safely, but we do need additional staff to continue to do this work. And, even putting in the cost of an FTE versus the cost of a readmission penalty. So I agree wholeheartedly. We can't depend on people above us to necessarily make the case for us. We'll be disappointed every time.
Mary Beth?
Yeah. So when we think about the challenges of proving our worth and value, and I'm thinking of this from a health plan perspective, I think one of the more granular challenges is getting on the same page in terms of the definitions we use. So the word engagement, Karen mentioned, we have to make sure we're engaging the members. Well, if you're from the health technology side of the room, that's going to mean one thing, engaging them through technology. I think for us as case managers, it means connecting with that member or the client or the patient through effective communication. And that takes skills that have nothing to do with financial numbers or, policies or processes. It's that balancing act we have to do between the science of case management, which is the systems we use, the evidence-based practice, with the art of it. And so for me, the challenge has always been demonstrating the value of the art of what we do and balancing that so that all the stakeholders, our leadership, understand that does add value. And again, I think that might be where these stories come in, that thick data that Dr. Hamilton was speaking of this morning.
Thank you. Karen, did you want to?
Yeah, to build off what Jose said a moment ago about, you know, at your C-suite level, it's black and white, it's numbers a lot of the time. And believe me, if there are any errors in your numbers, they will find them. So making sure that you have either the expertise or you partner with someone with the expertise to build your baseline data, your measurement period, and then measure that outcome. Whether it's a clinical outcome, it's a financial outcome, if you're running a pilot to try to prove the value of what you want to do, making sure that you have a solid plan in place, you have the numbers you need, and that you can then present it at the end with the outcome either way. And a lot of times we're surprised by numbers. We tend to go with, well, in my gut, I feel this. But I think we're past that time. We have to be able to prove our case, and you have to put some thought in that before you start it. You can't start the project and then think, oh, what am I going to measure? So that being prepared and building that plan.
Carrie, you look like you have a good answer.
One thing, I agree with everything that everybody has said, and everybody has spoken about this on a sort of a different levels. And I come from, you know, pretty much, I've been in all kinds of payer-provider environments and things like that, but I mostly come from the payer environment. And the interesting thing about it is that I have being here at this conference is always very important to me, and I've been absent for a few years, which has really been difficult. But coming back this year, it's been really fun for me because I had the pleasure of talking to a few people last night that I didn't know at all, that I just met, and that were first-time attendees here. And they were very excited about being here, and they wanted to hear all about how CMSA started and how, you know, people got the idea to go get together and all of this kind of stuff. And I started thinking about way back then in the late 80s, early 90s, when we really started the organization. And I thought about what case management was like then, because I was a line staff case manager then. And I remember all the phone calls that I made to parents. I do maternal child mostly, so parents and children, you know, and how people had no idea what a case manager was. And even in the healthcare system, people had no idea who a case manager was or what we did. And it was really interesting because as I've looked through these years and contributed to the development of this profession, as well as contributed to all of the jobs that I've done over the years, it's where we are today is an amazing evolution from where we were then. And so today, you know, we have a strong body of knowledge. We have a lot of publications. We have a lot of tools. We have a lot of very, very, very smart people that have put together all kinds of information. And what I would say to everyone here, no matter where you work or what your practice setting is or what your discipline is, avail yourself of all that information, because information and knowledge is power. And in any organization, with all the financial people, with your leaders, with the senior leadership, with the C-suite leadership, knowledge is power. And the more knowledge that you can give them and the more information that you can give them that is truly evidence-based and research-backed, that is going to get you where you need to be, as well as keeping an eye on the finances, because as we all know, you know, the world revolves around you know, whether we're profitable or not profitable, and if we can stay in business, because it is a very now, you know, competitive business out there. And so everybody does not survive. And I'm in the, today I'm in the Medicaid world. And so every 5 years, we have to renew a contract with the state, with any state. And so, you know, we have to prove our worth over and over and over. And we have to prove our way of being able to be innovative and being able to serve our members and the people that count on us. You know, these are very needy folks that count on us and very at risk. And we have to be able to find new ways of doing that. And so there is so many tools and so much available today that I would encourage everybody to avail themselves of information.
Good point.
Very good points. That's all okay? Okay. All right, now it's y'all's turn. Who has some seething questions they want to ask our expert panel? And please go to the mic.
Given Dr. Hamilton's presentation at noon today, or this morning, where do you see the biggest threats coming from AI, and the application of it for case managers? Because there was only one bucket of medicine that was really not being done better with artificial intelligence than a human being. And I think that's the intersection of case management with the patient. But I think there's a big threat around AI for the career.
Great question. Who would like to start that? It looks like Mary Beth.
I'm thinking.
Oh, okay. Who?
No, it is a good question.
Yeah.
I think, the artificial intelligence has already infiltrated healthcare in many ways, some of which we aren't even fully aware of. But I just keep thinking, how can artificial intelligence replace that key factor in case management practice, which is critical thinking and clinical judgment? That's really kind of the fulcrum of great case management practice. We implement our case management process. A huge piece of that is the assessment, the planning, involving the collaborative care team. That's got to take skills and processes that I don't think artificial intelligence can replace, but AI can definitely enhance the analytics part of what we do. So in terms of identifying members or clients or patients who are most likely to benefit from case management services, I think that's where the AI piece comes in. And those are just some quick thoughts, but it did leave me thinking the same thing this morning also.
I will tell you, none of these panelists have been prepped on anything prior. So this is all just from their expertise. The questions I had, they didn't know anything about. Jeannie wasn't planning on being on the panel, but she's taking Kathy Malahy's. So we love that. So this is why these are such great leaders in the field. Yes, Ann?
I think one area where artificial intelligence, as Mary Beth said, can help us is in the efficiency and the operations of what we do. But I don't think it's ever going to take the place of the human person being a case manager. And that's where we come in and we can thrive. Again, by letting people know what we do and how we do it and why we do it. And getting the feedback from our patients when we do work with them. So I think, there is definitely, and it's here and it's going to stay and it's going to grow, but our role as humans with that human feeling and empathy and support that we can give to people is special and can't be replaced by artificial intelligence.
So I will say this. I work for a company, a technology company, but we still use clinicians for engagement, face-to-face engagement. And I feel it's those two cornerstones together that make us successful. And even though we have a very accurate predictive analytics, we tell everyone it is a decision support tool. It does not tell you what to do with this patient. It is not recommending what the patient does. It is giving you more information to use with the information you get from that patient about their individual needs. And I think that's the part that I don't know how you program that in.
Right.
Jean? Oh, I'm sorry. Jeannie?
Yeah, I think in looking at the future of case management with the input and the support of AI, the critical piece of what we do has to do with the relationships. As Mary said in her talk, if you were able to hear that, it's all about relationships. So the skills and relationships that you can develop so that your time with the patients is more productive, if there's a way to enhance, those are the things that will differentiate you as an individual that can't be replaced. As you build trust with the patient, as you connect with them, that's the piece that can't be replaced.
Nancy?
I think that there's an impact or an ability of artificial intelligence to assist the case manager. It's going to come down to things like resources, things that we do dialing for dollars now. Maybe we will have those capabilities of having systems support us if we put in information on the social determinants of health and the compromise that our patients have, and maybe it will use that to give us information that'll help us be even more successful as we help that patient find their way through the healthcare continuum back into the community and hopefully to the goals that the patient wants to achieve.
Wonderful.
I know in our organization, the information the case manager gathers in his or her initial assessment on the patient is turned around and used as part of that patient profile in aggregate. So the work the case manager is doing on behalf of the patient also feeds into the artificial intelligence database to be used. So it's a two-way street. And I agree with everyone else that said, you know, we do need these tools, because before we're kind of just shooting in the dark, like, you know, not, you know, going one patient at a time. So having this big data is going to be very beneficial, and it's also a language that our finance people understand. However, once in a while, a patient will slip through the cracks that doesn't hit that high mark. So again, it's up to us to say, as Kathy would say, no, 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 even if they don't fit in that profile, they slipped out of the aggregate of being a high-risk patient. I know they're a high-risk patient because I have that relationship with them, and I know they're, if we don't intervene, bad things are going to happen. So that's where we can come in.
Okay. Did that answer your question? Did you hear that? Mm-hmm. Yeah, we just made a case for the CFO to say we don't need any more case managers.
Really? Is that what he heard? Somebody else? Yes. I don't think so.
I guess I can't agree with that statement. The statement was that we made a case to the CFO that we don't need more case managers. I think what we're saying is technology will help us work smarter so that we can enhance our ability to help those patients achieve the goals that they need to achieve. I don't think any computer system is ever going to provide a path to patient advocacy that each of you in this room provide. And it takes more of us, not less of us, to help the patients achieve those goals.
Okay. Yes, ma'am. San Antonio.
Yes, Leah from San Antonio. I do have to add one piece is when in 2001, when I started as a transplant case management, I remember we didn't have Google and the internet and the information we had, and you know, you've got 20 books at your workstation and you're pulling down, you know, where is that center of excellence for, you know, bone marrow and liver and that kind of stuff. So I really love the information that's out there. But on another note, our elderly population and dealing with them, I know that we have to embrace the millennials and everyone coming in. I am a late baby boomer, so I'm in those 4 years where I understand technology. I know the old way to do things, but we're dealing with elderly population now who are getting a prescription from the physician, understanding what the physician told them, and then they're going on the internet and doing a bunch of research. And vice versa, they're doing a bunch of research, they think they have something, they're going to the doctors. So that's one part of it. The other part is your elderly population who is not embracing technology. And you have to remember, and you're stepping back in using the old things, the old methods and such, and giving them the written information. And we can't forget that elderly population out there that is not embracing the technology.
Okay. Any comments on that?
Well, that is so true. I think that all of those statements are very true, and we have to always be mindful of the population that we're working with. The Medicare population has its challenges. The Medicaid population has its challenges as well. We have populations, I worked with an SMI population, serious mental illness, that had overlapping physical illnesses, very, very vulnerable populations. And we had to do things completely different with that population because they don't always go to the doctor. They die 25% sooner than the rest of the population. There's a whole lot of things that go along with that population. So I think that we have to, and that's part of, being human and part of understanding and being able to use our critical thinking skills and our empathy skills and all of those things we've learned over the years to be able to look at innovative ways of serving different populations. To that end, also, we look at very strongly race, ethnicity, and language, and the things that are barriers with some of our patients. And I know that depending on where you come from and what your race, ethnicity, language issues are yourself, we have to, as case managers, have a very open mind about a lot of that and be able to work with members and patients that have all kinds of different challenges that we face with them. And it just goes back to the tools that we have and the information that we have to be able to do a good job for all of them.
Thank you, Carrie. Anyone else? Okay. Yes.
Hi.
Hi.
So I just got done listening to a session on quality, and it was phenomenal. Charlie White did a wonderful job talking about the horizontal platform. And with healthcare changing, that's where I see our value added in a big way that I could make a case for any CFO on what we need to do. But I was very interested when I heard Jose mention that he was able to get what he needed. And from a 1,000-bed hospital, I always have needs. So recognizing that I'm over an acute care hospital, but now also 14 clinics and a rehab and psychiatric, I just wanted some words of wisdom on how I could gain some insight and get what I need.
Sure. So I think the first step in this whole process is we can't make the assumption that people know our worth. And so that's oftentimes the thing that happens is that people walk into a CFO's office, and I've worked for CFOs in the past, and I have a financial background, and so people say, I need an FTE. And I always ask, what's it for? Well, they're like, well, we can't do this. Well, have you done any optimization to see if you can remove any wastage time? And I hate to use it that word, but as case managers, we create processes because we're the expert case manager. Now imagine this. I have care management associates that have to work with several case managers. And their biggest frustration is they have 7 different processes for this same process because they have 7 different case managers. That is not an optimization concern of someone in finance that you're not utilizing your resources correctly. If you're building a new program, you have to have a baseline. You have to know what your expectations are and what the outcomes you're going to produce and how that benefits the organization. But when it comes down to when you have staff that does things their way because I've always done it this way and because I do a narrative note versus using my click boxes that I have in my Epic tool, then it becomes a little bit more of where you have to hold your teams accountable. So if you're coming to a CFO or anyone at the C-suite, because you're not optimizing, your answer is always going to be no. The advice I give you is present your case. These are the things that I've done to optimize my department. Here's where I still require resources, and here's the value add that I give you if you give me the resources. Otherwise, we won't improve the things that you're wanting us to improve. But I think it always has to start out in your own department, in your own area, because again, one of the things I've heard very loud and clear is we love to point the fingers at others and how they do it wrong. You know, I have case managers and social workers that constantly point the finger at each other. Well, at the end of the day, you're in the same department. Mm-hmm. We're doing it wrong as a department, so we need to figure out how we're doing it. One of the requirements that I've done in the past for leaders is they must all become advanced yellow belts in Six Sigma. Because if they understand the cost of poor quality, then they understand what they need to attack first, and you have to prioritize what is it you want. If you're new to an organization, take care of the low-hanging fruit first. Establish credibility. Once you establish credibility, then you can launch new programs. But don't come into a new organization and say, I want all these programs, because your CFO is automatically going to say no. So take care of the easy wins, get those optimization things fixed, and then you move forward. Hope that answered your question.
Yes, very much. Thank you.
Hi.
Hi.
My question is, as we move forward with programs with transitions of care at the outpatient level, we have physician groups who serve patients across multi-state lines that we either follow for 30 to 60, 90 days. How do we manage our care management teams, nurses, license level, when patients are utilizing the services or PCP groups or specialty groups within one state but reside in a different state or multiple states and often change locations of their living based off of family members or service? So if we're not providing direct patient care but transitional care or chronic disease management, how do you suggest to manage those licensures and continue to build seamless, engaging relationships with families?
Who wants that one?
Well, you know, we had, during the membership meeting, the National State Boards of Nursing was the leader of that who has led the multi-state licensure initiative was here. And he really, you know, showed how many states are already in the compact, more coming on. And again, CMSA, from a public policy standpoint, has been working on that individually with their states. It does take time, but it is moving forward. Florida became, I worked on Florida's for a number of years, but it won't, you're probably going to still have to have multiple licenses wherever your patients go. If the nurses are going to be working with them, if their state boards say that to do work in this state, you have to have a license, then you need to have a license in that state. So until your state becomes part of the compact, there really isn't a lot to offer except to get additional licenses. I think there's other people who work with nurses that are across state lines, so Karen might.
We do. We have our case managers, whatever state that they're assigned to where their patients reside, they have multiple licenses if they're not part of, if it's not a compact state, as Ann mentioned. It's the most stringent level, but we feel to protect them and to protect our organization, that's what we need to do.
So then my question is for the transition nurses who are embedded in the offices and the patients are seeing those physicians in those offices, any follow-up or transitional care if those patients live in another state would need dual license.
But are the patients coming into the doctor's offices?
Yes, but the nurses' follow-up is transition telephonic. For
Telephonically?
30 to 60, 90.
Yeah.
As I said, ours, we go with the highest standard just from a protection standpoint. So if we're outreaching to that patient in a different state, then we do look for licensure in that state.
Thank you.
I think you could, there's probably different interpretations on that, but
Go for the highest.
we just went for the highest.
And do remember, it's not, I don't know if I wasn't going to state, but it's where the physician, the treating physician is treating, not where the patient lives, which most of the time it's the same thing, but you have to keep that in mind.
But Kathy,
as to where the
I
license
think
is.
she said that her nurses are reaching out to patients out of state. So that would make it, they're crossing state lines to do that.
And that's definitely right.
Yeah, then you need to have the license. So get active on the Public Policy Committee.
There you go.
And get your
Yes.
state part of the compact. Where are you? What's your state?
What states are you?
Tennessee?
Yeah.
Illinois is not in the compact.
Not yet, yeah.
Oh, right, yeah.
How did we do that? Oh, we're licensed in Florida.
No. I can't hear.
The patient's somewhere else, yeah.
Okay. Yeah.
Yeah, in Florida, I live in Florida myself, and I'm from this area here in Chicago. We get a lot of patients who are snowbirds. I live in areas, in resort areas many times. I have been over the years. I don't so much anymore, but, and they come down, but we don't manage those patients once they go home. Generally, they have other physicians when they go home, and they have ways that they're managed there. And they transition into a different system when they're going home to their home state up north. When they're in Florida, however, we manage them in Florida. So we don't generally get, we don't have to get licenses in other states in many cases. However, if you are working in a large system where you have people that are like transplant patients, for instance, or patients that are going to centers of excellence in other states, and then they're going to be managed back and forth between two states, then it really behooves you to have somebody that has license in those particular states, because you're managing their care in more than one state. You know, that's the big issue to me. So then it would be what Karen was saying earlier, because, you know, then you're really taking a risk. You know, there's a risk in that state if you're not licensed in that state, if you're managing the actual care there.
Yes, ma'am.
Just an anecdote first, and then I have a follow-up question. But when I left the military and went to a civilian job as a case manager, the nursing orientation with the bedside nurses, they were telling them the answer is case management. Now, what is your question?
Oh, that's great.
We're working in an inpatient facility primarily. We don't do a lot of outpatient, and it's a 3-hospital system. And I was wondering if you could speak to where in the organizational chart you think case management should fall. We had a discussion with our director, and we don't always agree, so I told him I'm coming to this conference, and he said, ask that question.
It's a good question. Good question.
Who wants to grab that? Jose?
I will tell you that the place where you want to be is the closest place to the dollars. So I usually prefer to report to the CFO's office. And so probably in my career, I probably only had one job where I didn't report to the CFO. And the reason I say that is it is a lot harder to get resources if you fall under the chief nursing officer. This is my opinion. And so, and the reason is because bedside care is the primary driver. And so when you report to the CFO, you actually end up taking a lot more projects that are more in the financial area. But at the same time, I have a one-on-one usually with them every week. And so I'm able to start planting seeds for the things that I'm looking for. And also during the budget process, I know what the limitations are for the entire organization. So then I usually have to formulate my own game plan of what I need to do for my department based on what's going on. If you don't report to the CFO, it's always great to report to someone in the C-suite. The closer you are to the decision makers, the quicker you get to responses and answers that you need for your area.
If I could respond to that, that's exactly what we were feeling, because we're under nursing, but every time nursing doesn't or can't do something, they say, well, we'll just have case management do it.
I also have kind of a little bias too about, I think that nursing case management should be, especially in the hospital system, but also in health plans, I think they should be very closely aligned with quality. Because quality and care management really go hand in hand, and there's a lot of synergies back and forth between them. And so especially in today's world, where we're all responsible, and I'm very fond of saying it's not just the quality department that's doing quality, it's all of us that are doing quality. You can't really do everything in a health plan with quality by yourself in one department. So for us, I think that being closely aligned with quality is always a good plan, inside the hospital as well as outside.
They're happy, they're happy.
Yeah.
They like that answer.
Okay. Yes.
Hi.
Hi.
Along that same kind of idea, what's the panel's thoughts on the organization of CMSA of diversity in clinical experience? For instance, there are probably, I don't know the percentages, but there are certainly more nurses that are case management, social workers. What is the advantage of having other clinical specialties as case managers? I know they can. Are there any efforts going on to try to increase some diversity in that?
Question.
Mary?
Well, I mean, obviously, one of the beauties of CMSA is that we are an interprofessional group. But the preponderance of the specialties we represent are nursing and social work. But we do have other disciplines involved. I think also the value of working as a team. So even if the pharmacist is not a case manager, but if you have a clinical pharmacist who understands the goals that the patient sets and that you as a case manager are helping realize for in assisting the patient, then the whole team can come on board with the plans. So, CMSA definitely believes in the team approach and the interdisciplinary approach. However, everyone doesn't have to be a case manager. I mean, we do need to understand how all the different disciplines contribute to the care plan and to helping the patient achieve their goals. And I think particularly in acute care, that's what we see. We don't see other disciplines as case managers, although, I'll just say, with our alignment with physician advisors, so they're not case managers, but physician advisors that we work well with really understand the value of what case managers bring to the table. And they often can be an important stakeholder for us. As Jose said, they can advocate for us as a team and help work with us to show our value in really improving the clinical picture and outcomes for our patients, and ultimately the bottom line.
I just want to remind everyone what our standards of practice say, because we started today talking about standards. I think this is a good place to mention that the standards don't say you need to be a licensed healthcare professional. It has the "or" in there. And I'll probably say it wrong, so Mary Beth help me, that you have a baccalaureate degree in Health or Human Services. Right. So there are a lot of folks that bring skills to case management that aren't nurses, that aren't social workers, that, as Mary said, are members of the team that meet that other criteria that are detailed within the standards of practice. And I'm seeing more and more folks who have a variety of degrees that in health administration and in other areas that help support the knowledge base of case management. So I appreciate your question, because I'm going to challenge CMSA to do a deeper dive into who are the members and who are the folks that are serving in case management, not only in hospitals, but in managed care organizations, in patient-centered medical homes, and all the different environments where case managers are so prevalent today.
Ann?
I would really echo that, Nancy, and what Nancy said, and really look at, we can increase our membership by increasing people who are in case management across the disciplines. It would be great, and I think we tried to do that years ago. Look at pharmacists, invite physicians to be part of this organization, invite pharmacists, invite physical therapists. Maybe even just ask this audience, is everybody, what other discipline are you besides a nurse or a social worker? Are there other disciplines that are here? Physical therapists, right. So I mean, I think that's something that we as an organization can look at. Thank you for bringing it up, because I think it's a really important question. And today, because we are a team, maybe somebody who is part of like a rehab center, their physical therapy department could come here, present, be part of this conference, and be part of the organization, because we all can learn from each other as a team.
And I will say, in the post-acute care world, we are seeing more and more physical therapists as case managers. In fact, one of mine just got her CCM and was very excited about that. So PT, OT, speech therapist certainly have a role in that post-acute care world for sure. Respiratory.
Well, and that's a good point, because when we first started putting together the CCM process, the whole thing was to be very inclusive of other disciplines and other settings beside nursing and beside social work and the usual kind of stuff, because we recognize there are different patient populations, there are different members that require different skills. Within just the inpatient alone, it is amazing. There's always people, you all have experience with people that you can't move out of the hospital for a variety of reasons, that you really need a social worker to work with. And there are other times when we need somebody in mental health, exactly right. Now, in today's world, here's another thing. We're starting to talk, we're not starting to, we've been talking about it for a long time, but it's all of this integration between different disciplines with patients that have all kinds of different overlapping and overlaying problems. So we do need to have teams. And I am not a big proponent of cross-training. I did work for an organization where we had an SMI population, and they had physical health overlays, and the challenge was to really integrate those two processes, and I still think we have a long way to go with that, because we don't, typically, I'm not sure the answer is to take one person and to train them in both areas. I think that really we need to learn how to be much more collaborative than what we've been, and really put, we talk about teams a lot, but we don't always know. In my own organization, I've started, putting together some teams of people, but they don't really know how to work together. I kind of thought at the beginning that we were going to be able to work together really well, because we knew we all had a common goal, we were all trained, we were all doing this, but they're not working together. And so, there's some things that you really have to do to get people to work together in teams to really meet the needs of some of these really complex situations that you're going to run into.
Okay. Chris.
Yeah, I'm Chris Bartlett. I'm I'm the communications director for CMS UK, which is the equivalent in the United Kingdom. And one of the observations I made whilst I've been in the US is that it's very dominant nurse and social worker in your membership. Whereas in the UK, our model is very much nurse and therapy. So it's occupational therapy, physiotherapy. And how we've changed that really is that the director level within the organisation has such a multidisciplinary approach to it. So we've got physiotherapists, we've got nurses, we've got OTs, and we've got sports rehabbers. We've got all sorts of disciplines at board level, which has really helped spread that message across, which I think I've seen most of the board, and again, correct me if wrong, with CMSA, seems to be very nurse-led. But that's one of the things that we've done that's really diverse our membership.
Yes, that's a good point.
It's great. Thanks, Chris.
All right. Okay.
So I have a final question for the timing. Me first, because it's too far for me to walk. I got my hiking shoes, but I got 10,000 steps already. What words of wisdoms do the past presidents give me as the incoming president? So I'd really appreciate that without me having to walk all the way over there.
Let her answer first, and then we'll do that as a wrap-up.
Okay.
My question's related to the topic that we were just talking about, but you certainly can go first, that's
go
fine.
ahead.
No, why don't you go ahead and we can end on that?
I am the Director of Value-Based Care and Case Management for Orthopedic Group, who has been very innovative in going into the value-based care arena with BPCI and that sort of thing. And we're looking at sharing services with another orthopedic group who primarily has physical therapists as their case managers. Our model is RN case manager. And it was very interesting to me because the CEO of that organization was very resistant to and thinking that I would not want to be collaborative in setting up a new model of care for these patients. And when I said that I embrace therapy, and I think that there was a middle ground that we could all meet on and really, really serve the patients well, it really changed the context of what we're looking at doing for the patient. So I'm actually meeting with the lead therapist next week to try to come up with a model of care for these orthopedic bundle patients. And so I just want to say that the conversation's very relevant and the conversations are happening out there. And maybe we need, like you said, a representative from the physical therapy world to help us understand what they can bring to the table.
Okay. So now with Jose's question to the panel, what do you, go ahead, Jose, repeat your question.
I think the question was just what words of wisdom do you have from your presidency as I start mine tomorrow? And
I don't want to start. Go ahead.
Well, I'll start then. Lean on your executive director. I mean, that is, Jeannie Bowling got me through my presidency. I will tell you that. And I think that and just being open-minded, realizing everyone comes from different viewpoint, and it's not necessarily your responsibility as president to voice your viewpoint or your opinion as much as guide the conversation around so that we come to a collective decision that's best for the organization.
I'd have to echo what Karen said, and also I think really just be open to the advances that we're seeing here in healthcare and we really need to invite people who are in healthcare as teams to be part of our organization. I would love you to reach out, or love this organization to reach out to Atul Gawande, who just got named to the that Hathaway's, Amazon, Morgan Stanley. He's going to be the medical director of that conglomerate.
He's going to be the CEO.
Yeah, he's the CEO. He really, I think, understands what we do. He understands who we are, and if we could get part of that, at least our foot in the door with him, that would be great. But really, I think the sky's the limit, Jose, with your intelligence, with your academic preparation. I really look forward to you having a great year and really transforming and helping CMSA to grow stronger and better because of the issues we're in healthcare today, because we can make a difference.
Yeah, I think that's very true. I think that collaboration, what I would say is, because I was a very collaborative president, I was in the early years, so things weren't exactly the same as they are today, but I think the same tenets hold true. that as president of CMSA, you're the face of CMSA and the voice of CMSA. And we have a lot of diverse membership. We have a partnership now with CCM, which in my years, we didn't have. And we've had some difficult years back and forth with CCM. And so I think this is a golden opportunity to really help members understand what's out there and what's available. And I think it's a golden opportunity to really be collaborative and to be open. And to do that, you have to make sure you're saying the same thing all the time. You have to make sure you're not saying one thing to one and something else to somebody else. People pick up on all of that. And sometimes that's not easy to do. As a president, it's not easy to do. There are a lot of pressures involved there. So collaboration and bringing people into the organization, and anytime you have a fight with somebody or you have a difference of opinion with somebody, bring them to the table. It's so much easier to do that than to, not do that. So that would be mine.
Jose, I agree 110% with everything that's been said. And one thing I would say is to help CMSA make sure that our standards of practice can be put into everyday practice at the individual level, providing the education and support that frontline case managers need, at the organizational level with the, just the leadership development that CMSA can offer, and at the public policy level. I mean, we have to keep moving forward with our public policy efforts.
My only thought is, we learn from the past, but you are the future of this organization, and you're going to help design the future not only of this organization, but the future of the practice of case management. So keeping your ear to the ground to hear the needs of the members, but always with the eye on what is the future vision of case management.
Yeah, well said.
So I agree with all of my esteemed colleagues. I would also say that for me, it's always been about relationships. So, everyone, all of your members, your past presidents, your board, everyone wants you to be a successful leader. And if you succeed, we succeed. And so we're behind you 100%, and we want to support you in any way we can. And, we definitely believe in your ability to carry our wonderful organization forward.
Very good.
During my time that I was able to serve as executive director, I had the privilege of working with about 15 different presidents. Everybody has their own personality. Everybody is gifted in different ways. I think the challenge is to use the gifts that you have, remembering that you're serving the membership. Listen really carefully to the members. Work with just hand in hand with the executive director, because that person has the privilege of having different kinds of feedback from the membership. And together with the board, if everybody is dedicated to truly listening, looking at the future, and trying to work together truly as a team, you will have a magnificent year, and I know you will. 2 years, that is, 2 years.
2 years, 1 year.
2 years, right, 2 years.
Kathy, can I say one more thing?
Pardon?
I just want to say thank you to everybody who's here, who's interested in all of this. I want to say thank you to everybody that's on this panel, and it's been my pleasure for many, many, many years to work with amazing people in everything that I've done, especially related to the building of this industry and this practice. And so I just want to say thanks to everybody. Everybody has their own unique personality. They have their own gifts, their own talents, and it's been a total pleasure to be part of this organization for as long as I have.
Okay. Thank you, everyone. Thank you for being here. Have a wonderful evening.
We'll see you tomorrow.
Yes.
Bright and early.